Welcome to ESD School, brought to you by Attract. Don't forget to subscribe to the channel so you don't miss a single episode. Enjoy the video.
So good morning, and it's nice to see you again on the YouTube channel ESD School. Today, and it will be our Christmas gift, we will discuss about vessels management and bleeding. You will see it's not only for people who are doing ESD, but you will have to manage and to be very skilled in bleeding management and in prevention of bleeding to do ESD, because if you spend a lot of time to obtain coagulation, it is very difficult to deal with. It makes you crazy, very sad, and it's probably a point that make a lot of people stop ESD because it's difficult to manage, particularly in the stomach and the rectum. So you can see here all the episodes in gray that have been treated now, and today we will discuss about bleeding, but more than bleeding, vessels management. So first, to see the vessels and to treat the vessels and to prevent bleeding, you need to be in the submucosa. And for this, you should have done a good incision, a good trimming, and if possible, have a traction strategy, because it will improve the exposure and therefore make the vessels more visible and more easy to control. So the theory, first, how vessels are organized in the submucosa, because it's important to know it. Second point, the best bleeding is the one that you don't create. So first, try to prevent bleedings by treating the vessels before bleeding. And when it comes, bleeding management. We will see the devices used for bleeding management, the training exercise, and some examples. So first, submucosal vessels anatomy. You should have the picture of a chandelier. Because the vessel is coming from the muscle with one trunk, and after it will divide in many different branches. So when you want to treat, you should expose the main vessel, the trunk, like this one on the lower part. So you will have to cut it from the trunk, not very close from the muscle, because if you do it and it bleeds, it will be difficult to control the bleeding. But you should find the trunk and try to treat it relatively close to the muscle, but letting something that is easily catchable by the forceps, for example, in order to make the bleeding easy to control if you create a bleeding by doing your coagulation. So once again, it is a chandelier coming from the muscle and dividing later in many branches, and it's easier to have a cutting line very close to the muscle in order to cut only one large chunk instead of having to deal with a lot of small branches. So please try to expose your submucosa thanks to traction in order to be able to choose your cutting line close to the muscle. Therefore, you can dissect the submucosa in order to have a good exposure of the vessel trunk, and after it will be really easier to cut the vessel very slowly and to avoid bleeding first, but also to control bleeding if you create a bleeding. So try to be cautious, dissect on the right, on the left, and then cut the vessel when it is easily visible and when it is easily catchable by a forceps. We will see all these points in detail. So next, prevention of bleeding. So first point, which is very frequently a question, should we use epinephrine? In fact, it could be useful theoretically, but in fact, even in the stomach, there is no clear demonstration in a randomized trial, except possibly to reduce the duration of procedure, but not so much. So, in fact, it's not a fault if you're using it. It's not a fault if you don't like it, because it creates a whitening of the mucosa, and the effect is probably not null but very small compared to exposure of the submucosa, seeing the vessels very well, etc. So first, to prevent bleeding, you should see the vessels. It's very important. It seems very easy, but in fact, if you have submucosa front of your vessel, you will have a surprise when you will cut it. So you have to dissect quite slowly, and when the vessel appears, you will dissect on the left to open the space, on the right to open the space again, and when you have only the vessel at the middle, you will be able to coagulate either with the knife in this first example or with the forceps in the second example. So this is an example of relatively large trunk coming from the muscle once again. Usually you have more than one vessel, they are joined, one artery and one vein, so you will in fact dissect and coagulate two vessels at the same time. And your aim is to see very well the vessel. So you will dissect on the right and then on the left, and slowly you will have a vessel which is clearly visible, easily, and which is ready to be treated. I mean, you will coagulate not from the front side, but from the lateral area. And on the lateral area, your knife or your forceps has more space to coagulate the vessel. The worst situation is when you will damage the vessel with the tip of your device, because the space is not open around, and therefore it is very difficult to obtain hemostasis. But if you come from the lateral side, all the blade, all the tip of your knife is coagulating, and therefore you have really more contact with the vessel, and it makes things really easier to deal with. You see here the vessel, it's quite easy to see and to check, and therefore we will coagulate slowly with the knife, and finally we will cut the area in order to go further in the ESD. And after, it lets a small yellowish area, which is the fatty tissue and the fibrosis, which is coming with the vessel itself. On the lateral side, you see like this, because you have exposed your vessel. Same example, exactly, you dissect first to see the vessel, and then on the left, and then on the right, and this is to obtain something that is easily catchable with the forceps, and therefore it's more easy to obtain hemostasis. So you will create a better situation for you because you in fact prepare the fact that the forceps will be easy to place and to obtain hemostasis. So here we use a coagulation forceps. You will see I coagulate with force coagulation. We will see and I cut. But in fact here the bleeding is coming, but because exposure is very good, it's quite easy to obtain hemostasis. Second case, second vessel, I catch it, and when it is good, I can cut with the forceps itself and go further in my ESD. Second example, same. I prepare the vessel on the left, on the right, and sometimes when the vessels are really joined, I can catch the two vessels at the same time, or sometimes you should take the two separately because the trunk is too close to the muscle, and if you choose to coagulate the trunk itself, it is almost difficult to obtain the hemostasis without damaging the muscle or without being very close to the muscle, which is more difficult to deal with if there is a bleeding. Because if the bleeding comes from the muscle itself, you have to coagulate on the muscle and it creates this kind of whitish area. So try to coagulate not on the muscle but just above to avoid damage on the muscle. So next, the bleeding management. First, we have tried to prevent the bleedings, and now we will manage the coagulation. It is not the most easy part of our work. What is important to understand is that it will make you crazy sometimes because bleeding is a stressful situation. So first is to keep calm. It's not so easy, but you should use everything to keep calm. And it means you have to prepare everything before cutting a vessel, before doing an ESD. It's not when it becomes to bleed that you ask to the nurse to go to find a coagulation forceps. You should have prepared it before. You should know that bleeding will come. It's very difficult to have a perfect ESD seeing all the vessels without any surprise. So it will come. It's a part of the procedure. And in our life, only one case could not be controlled at all and went to surgery. Only one on more than 2,000 or 3,000 ESD, I don't know exactly. So you will manage. You just keep calm. You breathe. You ask the friend if it's not difficult in the room close to yours. And after, you manage it. But whatever, if it takes a lot of time to obtain the coagulation, it will be a very stressful situation and it makes you tired. So try to prevent it as much as possible in the bloody situation. Breathe, keep calm, think to the very nice place you like for me, my own hometown in Cantal, and think to your children, think to something very good, and therefore it will be easier to control the bleeding. And sometimes by breathing, you will find a solution by taking a new tool, exposing better, trying to push with your cap, many small things that make you able to control the bleeding. Sometimes you want to reach the hemostasis very quickly, and in fact, you are losing time. We should elevate our level when it bleeds. I mean, it's not very effective to try to catch a bleeding very far from it. It's more precise to try to see clearly the area and obtain a very precise hemostasis. But we will see it again. So don't think you are a bad guy if you become crazy when it bleeds. I am this kind of guy that becomes crazy when it is bleeding. So first thing, you should think about gravity, because sometimes gravity is an enemy. And if you turn the patient, it will become a friend. So this is an example of bleeding where we obtain the hemostasis very easily after turning the patient. Because at the beginning it was very difficult because all the blood comes on the area. It was quite an under-blood resection, which is very difficult. But once we turn the patient on the left, the blood comes away, and it was really easy to see the area and to see the bleeding point more clearly. Hemostasis was not easy to obtain in this case, but at least I could see where was the bleeding, because trying to obtain the vessel unprecisely under blood is quite a loss of time. In fact, you will never manage to do it very precisely. So next point, a new tool which is for me very useful to reduce stress and to obtain an hemostasis more easily is the red dichromatic imaging coming from Olympus, which is a new mode that allows to see the bleeding point within the blood lake. So it is not absolutely perfect. I mean, you will not have a red circle around the vessel. It's not AI, but it is sometimes the thing that makes you able to see in 1 second when the vessel is bloody. You will see the bleeding point and catch it more easily. So in my practice, I have a mode which is done for diagnostic with NBI, Zoom, everything. And when I begin the ESD, I change to a therapeutic mode on the AV61 unit in order to have the RDI on the first button. It means I will be able to find it very easily. This is an example here of bleeding management under RDI. In fact, there is 2 points, I think. It's easier to see the bleeding point, so you will save time. It was demonstrated in a randomized trial. You save time, you improve your bleeding point detection, you are more precise, all these points. And another point, it's not red. And in our brain, it's not the same. I get not stressed when the blood appears orange or yellow compared to red. And it was demonstrated in the randomized trial with physicians who did this study because their blood rate was lower, seeing the blood in yellow with a bleeding point improved compared to doing it in red. Their eyes movement were reduced with a camera that was recorded their eyes movement, and also the blood rate was reduced. So I'm not the only one that seems better and less stress when it's yellow compared to when it's totally red. So here it's a bleeding unsuspected or unattended. It becomes red in turn, but thanks to the RDI, you have the impression that there is less blood and that you see better the bleeding point within the blood lake. You will see here. And therefore, you becomes very precise because you see clearly where you should treat. And it's not something you do anywhere to control the bleeding. And for me, once again, it makes you less stress and more confident to obtain the hemostasis.
Donc là, diagnostic, thérapeutique. Oui. Voilà. Thérapeutique.
So now we will see the different tricks to obtain hemostasis when there is a bleeding. First, and probably the most effective and the better choice, if you can, is to compress the bleeding point with the cap. It's very important when bleeding is coming into your cap and make your vision impossible. You should slide a little and try to push on the vessel with the cap, so it makes you able to insert your device of coagulation and to have a coagulation effective by reducing the blood flow. So first, if possible, try to have a compression with the cap of the area which is bloody. Second thing, if the bleeding comes from the submucosal plane, it's a good choice to inject with the knife in order to increase the pressure. The fact that you will increase the pressure will reduce the blood flow and you will be able to have an hemostasis. So this is an example. The blood flow is important. I don't see very well where it comes. And when you inject a lot, it reduces the blood flow, it washes a little, and therefore it's easier to have the control of the hemostasis by seeing better where the blood comes from. Next, the suction of the area. If you are not able to obtain the hemostasis by pushing with the cap, you can try to suction the area of the vessel in order to stop the bleeding while you are inserting your device. This is an example. It is difficult because the blood flow is coming to the cap. Even using RDI, it's difficult to see where the bleeding point is. So finally, I need more time to insert my forceps. I do a suction, like now. The blood is coming into my channel. Probably the compression of the muscle makes the stop of the bleeding, and I add the time to insert my grasper for coagulation, and therefore I obtain the hemostasis of the vessel coming from the muscle. So when compression is not possible, when injection of the area is not effective or not possible, suction of the area is also a good tips to obtain the stop of the bleeding. So now, how to stop a bleeding when it comes? It's very important because for a plumber, for example, it's not a good idea to put something on the hole. It will stop the bleeding a small moment, but rapidly it will come again. The good solution in this case is to stop the flow. And here I will show you two examples where coagulation of the hole is not a good idea because in fact it will increase the hole. On the opposite, you see the vessels coming from the left, and if you go to the vessel itself and coagulate the vessel on a larger area, you will stop the bleeding in fact because you have stopped the flow. Second example, to be clear, you can see the bleeding point here. It doesn't stop, but while you are seeing where the vessel comes from, you stop the flow and it stops the bleeding. So very important, try to analyze the area, not to coagulate the hole in the flow, in the vessel, but the vessel itself outside the hole in order to have more surface of contact to coagulate the area. And it will stop the flow definitely. Next, when you don't see where the bleeding comes from, it's very difficult. So if you are doing an incision and it creates a bleeding, don't stop your incision. Do an incision again to open the space and see clearly where it comes from. So if you have a bleeding like this, please dissect again to enlarge the space and see where the bleeding comes from. It's very important. It's very, very difficult to stop the bleeding if you don't see where it comes from. If on the opposite, you have a bleeding that occurs during the section, don't stop. You inject, you go further, you coagulate a little, you don't see where it comes from, so I go again, I don't care of the bleeding, I open the space, and once it becomes to be open, I will be able to enter into the area, coagulate again, I inject to improve the exposure, open the space, and therefore it will become visible where the bleeding comes from. Also at the beginning, when it was really blinded in the area, it was very difficult to see where it comes from. So once again, I will do a larger incision. I increase again my incision, and sometimes by doing this, you will coagulate the vessel because in fact it was in the angle of your incision and you didn't see where it comes from. So once again, it is sometimes difficult to see where the blood flow comes from. Open the space first to be able to detect the bleeding point. If you don't see the bleeding point, it's very imprecise coagulation and therefore very difficult to obtain hemostasis. Same thing if you are in the submucosa and the bleeding comes from a blind area. Here it comes from behind the submucosa. It's not a very big bleeding, but it comes from the submucosa blind by the wall front of him. I will dissect first. So here, not very precise movement, sorry. I think I'm doing something else at the same time, changing for example, the generator or something like this. And therefore, we will dissect, open the space, and it will begin something we see better, and we will be able to see really where the bleeding comes from, because at the beginning the bleeding comes from a small hole in the vessel, but we didn't see clearly where it comes from. So proceed in your dissection until you see really the bleeding point. Before seeing it, it's something imprecise that will never go to a stable and a durable hemostasis. So dissect, 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 and once you see clearly where the vessel comes from, you do a precise coagulation. Don't stop dissecting or doing your incision because there is a bleeding. Expose your area and control the bleeding point. Next, sometimes it's very difficult to see the bleeding point once you are doing. So I cut voluntarily to see, but in fact I'm totally lost because a lot of blood is coming. So it was not very easy to expose the area. So I decided to use the traction strategy despite the fact it was bleeding in order to improve my exposure of the area. And the clip itself make a weight that open the space and make easier the visibility of the area. So I could catch the rubber band and fix it on the opposite wall in order to see better where it comes from. And once the exposure is better, okay, there is a bleeding, we should do it relatively quickly, but once it is exposed, we can see where the vessels come from and how to coagulate it. Before, it was very difficult because the blood stays in this area and the edge of the lesion covered the area of the bleeding, and therefore I didn't see anything. So using the traction as an exposure for controlling a bleeding is also a good point when you don't manage to do it without a good exposure. Next, a different kind of bleeding is the hematoma. Hematoma are due to a shallow submucosal injection that create a dissection of the muscularis mucosa. The problem is that sometimes the bleeding comes from far from the area, and it will create a flow of bleeding, not very important, but during the wool procedure. And sometimes you should open clearly the hematoma and coagulate the bleeding point, because if you don't do so, you will have a blood flow during the wool procedure, which make your vision not very good, and in fact it's easier to control it once and to stop dealing with this one. Next, now the devices we need for a good coagulation. So I have listed here all the points that makes effective your hemostasis. You need a good scope with at least a 3.2 millimeter channel under this threshold of 3.2 millimeter. The devices are in between 2.2 and 2.8 millimeter for the knife. Same for a coagulation forceps, and if you don't have a good channel, you will lose all the capability of suctioning the bleeding. So 3.2 for me is the good threshold in between a small channel where the device is moving with you and a good suctioning power. Oriented flushing on the device is also very important. On the new scope, the flow of flushing is coming on the knife and therefore is washing the area where you want to coagulate. The old scope had a 9 o'clock washing and a 7 o'clock device, so you had to move your scope to wash and therefore come back to coagulate. And this movement can be avoided by an oriented flushing on the area. The cap is for me absolutely unavailable. RDI is something that helps me a lot. 2 flushing pumps, one for the knife to inject and one for flushing in the channel. The generator of coagulation, we will see it just later. The IPFix fixator is for me very important because bleeding are the part of the procedure where the change of pedals is more frequent because you will flush, inject, coagulate, flush, inject, etc. So you need to find your pedals, keeping your eyes on the screen and not looking for the pedals at the bottom of your foot. You will need a knife which is able to coagulate and a coagulation forceps when the bleeding or the vessels cannot be managed without using a larger device. Second thing, my settings, of our settings in my team, when we use the knife as a coagulator, we use swift coagulation because with a needle type knife, the surface of contact is very small, so you need a lot of power in coagulation, and forced and soft are not so effective with the knife. So when I want to coagulate something with the knife, I stay in swift, but when I use a larger surface of contact, like a forceps, I use forced coagulation with a relatively small effect in order to have an important coagulation, but relatively quickly. The problem with soft coagulation is that it takes time, and sometimes you have a diffusion, a spreading of current, and a coagulation that goes around the area you want to coagulate. With forced, it is going faster, but you stay on the area without spreading around. Next thing, which is relatively important, is the use of the black button in between your cutting and your coagulation area, because you can switch the system from one mode to another mode. So you can do it alone, switching from swift coagulation with the knife to forced or soft coagulation if you use soft, but without asking to the nurse to go to the generator or something. You can do it by yourself with the commutation button. Next, it is an important thing also when we see the people that are less experienced in ESD. When they have a bleeding, they wash a lot. But in fact, the good way is probably to flush a little, remove the blood, and when it bleeds again, you will flush a little, and then you will flush slowly, remove the blood, and see again. If you wash a lot, you will create a lake of blood, which is sometimes effective when you can stay underwater without making everything red. But most of the time, if you flush continuously, you don't see really well where it comes from, and the blood is mixing with the water, and therefore it becomes totally red. It will probably change if we have under gel resection in the future, but for the moment with water, the mixing with the blood is very important, and therefore the area becomes totally blind. So for me, the good way is to flush alternatively. You will see a bleeding here. a new example. I inject first. I think I will control this vessel, but in fact, I get a relatively strong bleeding. So once again, I try to come close with the cap in order to have a better vision of the area and to create a small area, but it's not so easy. I flush and stop. And in this case, it was quite feasible to compress and stay underwater. So it was relatively effective at the beginning to stay underwater, but in fact, the blood is mixing and everything becomes totally invisible. And after, I wash slowly, see where it comes, wash, see where it comes. So except in an underwater strategy where it makes you able to see where it comes from, you should more flush gently and alternatively than flush a lot and make a blood lake front of you. Next, the training exercise. When a bleeding occurred in an opened area, try to stop it without any tool, without any coagulation tool. I mean, once you get a bleeding, you try to stop it with the cap compression, with injection in the submucosa, or with suction of the area. It is not so easy, but it's a very good training exercise. Try to stop the bleeding before inserting your coagulation forceps or your knife, or during this. Try to stop it only with mechanical devices, I mean compression, suction, or injection in the submucosa. And last thing, too active to control. Second example, using more elements, but we saw it previously. It's another thing. The bleeding comes, you try to go close to it in order to compress it with the cap. Once you have less blood flow, using RDI will help to see clearly where it comes from. And at the end, you will be able, by removing your cap, to decrease the compression on the vessel, and you will see really precisely where it comes from. So if your device is ready, you can coagulate. If it's not ready, you go back to compression and comes with your device. And in this case, you see, we coagulate quite far from the muscle in order to coagulate the vessel itself. Last example here, where we will use cap compression with the edge of your cap in order to have a control on the bleeding itself. Flushing gently, injection in the submucosa, and when the blood flow becomes clear, it's easier to control the bleeding point by coagulating the vessel itself, and if possible, not the hole in the vessel. So finally, and to summarize, the best bleeding is the one that does not occur. So you should know the anatomy of the vessels in the submucosa, like a chandelier. You should prepare your vessel by dissecting it everywhere in order to be able to see where it comes from and to be able to catch it with a forceps if it bleeds. And if bleeding occurs, it will come. It's a part of the procedure. Please stay cool, ready, breath, elevate your level to be precise, and to use all the tricks: compression with caps, suction, detection with RDI, flushing gently, precision of cap, everything in order to create the good situation to see the bleeding point and coagulate it quickly. It will save time and a lot of energy. And what I can advise you for training is to always try to be precise, even if it seems easy to control. Not catch with a large forceps everything. Try to be precise on the bleeding point every time, because with the training you will become more and more effective and save time and energy during the bleeding phase that are really stressful. And finally, it stays me to wish you a Merry Christmas and to propose to you to come with us during EndoGastro Live 2024 in January. The session about ESD will be in English, and we will try to share all our tips and tricks. It's a free event trying to be sustainable ecologically by reducing the trips of all the experts. Every city have done the cases with experts coming from the surrounding region, and we try to do it online to reduce the impact, trying to reduce the number of people who have to move to get training and knowledge about ESD. Thank you very much, and hope it will help you for your next bleeding cases. Thank you.
Thank you for watching. If you found this video helpful, please give it a thumbs up, subscribe, and share it with your colleagues. Until next time, this is ESD School by Attract.